Welcome to Variations 4. This is a unit on shock. In this video, we'll be covering question 1 to 3. Number 1, explain the difference between shock that is from low blood flow versus shock that is from maldistribution of blood flow. Well, let's talk about the maldistribution of blood flow shock first. First of all, there's 5 different kinds of shock we're talking about in this unit, and they're listed here. You can see them right across here, these 5. 3 of them, well, first of all, let's take even more of a step back. What is shock? What is shock in one sentence? What's the problem with shock? That all of these have in common. All 5 of these have it in common. What is the problem with shock? It's low perfusion or decreased perfusion to organs. That's the problem they all have. And so these are 5 circumstances, or 5 rather conditions that can lead to that decreased perfusion to key organs. 3 of them you could classify into maldistribution of blood flow. And that is with these 3 here, septic, anaphylactic, and neurogenic, there isn't necessarily any loss of fluid or any problem with the heart per se. The main issue here is that fluid has moved with all 3 of these, as we'll see, because they all involve an inflammatory response. Well, these 2 involve an inflammatory response, and this one involves basically an inhibition of the sympathetic system, yielding vasodilation. So they all have vasodilation in common. Fluid is blood pressure either drops, and in these 2 cases especially, moves to the tissues. So with all 3 of them, the problem isn't decreased fluids in general, and the problem isn't cardiac in origin per se. The main problem with these ones is we've got decreased pressure in the blood vessels because either we're in a vasodilated state, like in neurogenic shock, or because of the increased permeability of these 2, blood has shifted, or the serum portion of blood, water portion of blood shifted to tissues. And that's why we call these maldistribution of blood flow. The first 2 here, cardiogenic and hypovolemic, do not necessarily, or at least do not initially fall into these categories. The main issue with cardiogenic is you've got a problem such as the heart is failing, and so it can't pump the blood, and so blood's just not arriving to the organs. The second one, hypovolemic, is just straight up, you're either seriously dehydrated or you've lost a lot of blood. The problem is not that the fluids have shifted somewhere else. The problem is that either they cannot be moved, cardiogenic, or you just don't have enough there, such as bleeding or dehydration. Question number 2, explain the patho of cardiogenic shock. Let's look at figure 69.2 for that, and that's right in your PowerPoint. So in the 4th edition of Lewis, it's figure 69.2. In older editions, it's 68.2. But so excuse me if I get those numbers mixed up, but it's really the same stuff we're talking about, and you are definitely safe to refer to the resources I have given you in Moodle, such as this PowerPoint. Even if they don't exactly line up with the most current text, these are safe to use unless otherwise said. So there's 2 interesting parts of the cardiogenic shock here. The first one's really obvious, and it's one we always think of, and that is if cardiac output is decreased because of whatever, there could be a ton of different problems that could be affecting the heart. Anything from an infection to valve issues, to rhythm issues, to filling or emptying issues. And we don't need to go into all that. We went into some of that already in previous units. But the bottom line is there's some kind of dysfunction with the heart that is decreasing cardiac output. And we know that if we decrease cardiac output, at the end of the day, blood pressure is going to drop, tissue perfusion is going to drop. So that is obvious. We already know that. It's nothing new. Just the reason I brought this diagram up is because the added side of things here is interesting as well. If you have ineffective filling, if you think about it, if you have ineffective filling, let's say the left atria, just take that for an example. Let's say the left atria is having, atrium is having problem filling. What's happening then? This is just one example of what could happen. Blood is backing up now into the pulmonary region, increasing pulmonary pressures, increasing pulmonary edema. And we already, as we talked about in previous units, when you have increased fluid on the pulmonary tissues, your oxygenation, your gas exchange does not happen efficiently, and that contributes to decreased oxygen supply, which also contributes to decreased tissue perfusion. And we just got the same explanation given down here in written form, just kind of expanding on what I said about pulmonary pressures. Actually, that hydrostatic pressure from the congestion is what increases fluid on the tissues, which decreases oxygen exchange at that site. Finally, question number 3. I guess we'll kind of wrap all this into that, and that is explain the physiology of each sign and symptom on this head-to-toe map. It might wrap up a lot of what we said. Let's take a look at that. So that's map number 2. So a lot of stuff here for cardiogenic shock based on what we've talked about in this unit and especially previous units should be pretty intuitive if we think about what shock means and the fact that it's cardiogenic in nature. Pulse pressure dropping, pulse pressure narrowing is a fancy way of saying systolic blood pressure is going to drop more than diastolic, and that's normal. That's nothing. That's not news to us. You decrease bowel sounds, increased chance of ileus whenever you have shock is intuitive for all your shocks because decreased blood flow to core organs means the body has to choose where it wants to send the blood. And so let's face it, the bowels and digestion is not a priority. So you get all those kind of bowel symptoms and issues. Labs, we are going to talk about that a little later. We'll do kind of a grand summary of lab work later on. But these ones should make sense right here, especially if you think of these first 3. Decreased perfusion affects your kidney function. You may have increased sodium. And, if that's a high sodium diet, this is what can cause cardiogenic issues to begin with. That could increase the CHF. Also, another way of looking at it is the drop in blood pressure might be causing aldosterone to be released, which would decrease your K, as we talked about earlier units, and that would also increase your sodium and hopefully get your water retaining as well. I mean, it just depends on how you look at this. This could be up because the guy's got a bad diet, or it could be up because of the aldosterone.